I have been working with Living Beyond Breast Cancer for about 2 decades, and I've given a talk on the topic of treatment options and opportunities and how to make them in the setting of living with metastatic breast cancer more than once. And what I always love to share with everyone is that this talk gets harder and harder to give in the time limits that I am provided for these conferences because there are just so many things that we could choose to cover today. So I'm going to highlight a few things, but then I really want to make sure we leave enough time for your guys' questions and our discussion because I want to hear what you guys have to say today. But I just picked some things that I think are today's top burning highlights. Little bit about me. So, you can look at my professional credentials, but I think it's also important to know like who you're talking to because you guys often share a lot of personal information. So I'm going to do that the same. I was born in Jersey, did all my medical training up in the Boston area, and I've been out here at the University of Colorado for 20 years. I've had an academic career the whole time. My journey with cancer started when I lost my 23-year-old sister when I was 10. It was not anything related to breast cancer, but she had complications from her treatment. I have two boys. They're 18 and 21. I have a new husband. I'm actually a newlywed. And I have an old pair of twin girls, a boxer who you hopefully will not hear from this morning, and a Norwegian forest cat. They're my twins. They're 9. I've been treating metastatic breast cancer my entire career, which I started my oncology fellowship when I was 28. I personally specialize in young women's breast cancer, but the reality is I treat all types. And in young women's breast cancer, I end up seeing a ton of just about everything: inflammatory, triple negative, HER2 positive, ER positive, you name it. One of the weird things about me as an oncologist is one of the first patients I ever treated for metastatic breast cancer is alive and well. I'm currently 54 and she's 57. And she's just one of many, but it was a pretty formative experience in my early career as to what we could achieve if we understood the disease well and had good drugs that target the targets that make the difference. So one of the important things I think also for today's topic is just defining some terms because we like to throw some things around and not everybody is super familiar with them. So whenever you're talking with a doctor, you always have to make sure that you understand what they mean when they say things. And, we're talking about being a long-term survivor with breast cancer. And what I think is really a joyful aspect of this is that definition means a whole lot different now to me than it did 20 years ago. When I started my career, the life expectancy of someone with metastatic breast cancer was about 2 years. And now that is not even, remotely where we are. The subtype of the breast cancer matters, these markers, and we're going to get into that in a minute here. But there are certainly some subtypes of breast cancer which we've been able to achieve serious long-term survival for a larger portion of our patients, and some where we still need better advances to match that. The example I gave you of the patient who I've taken care of since the start of my career was that she was HER2 positive and she came onto a clinical trial with a drug nobody had heard of for a target nobody had heard of back then. And as you can imagine, that drug is trastuzumab, or commonly known as Herceptin, and she was one of my first patients I ever treated with that. And so, certainly in the HER2 space, we have patients who are living decades with metastatic breast cancer, and all the way to the opposite end of the spectrum where we have triple negative breast cancer, where I still have patients who are living for many years, but it is not as frequent and it's not as easy, and the challenges there need more science and more advances. When you decide to look at Twitter or Dr. Google or other online sources, just be careful because some of these track statistics from the time that a person was initially diagnosed, like maybe they were originally diagnosed with stage 1, stage 2, and then they developed a metastatic recurrence versus if they had metastatic breast cancer from the outset, or they're just talking about statistics from when the metastatic breast cancer began for that person. And the other thing I will emphasize is that the longer any one person facing metastatic breast cancer lives, the less the statistics from any given clinical trial or any new advance actually applies, because there is a certain understanding that people whose cancers are responsive to treatment, particularly in the early setting of first line, second line, etc., tend to continue to benefit more than when we are encountering cancers that really are quite difficult to treat and don't respond to therapies. And so, if anything, I think long-term means a really different thing now, and we need to make it mean even more. Terms that doctors will use, or patients will use, or folks living with MBC will use, are things like NED, no evidence of disease. Or I kind of prefer NEAD, no evidence of active disease, because anyone who's ever had a bone metastasis, we can still see remnants of that on imaging, but lots of things to suggest that the cancer really is in a dormant state. And we also have folks who are exceptional responders. I have patients who are still on their first line of therapy many, many years into their treatment, well past what any results of the clinical trial would have suggested would have been the average length of time that they are benefiting from it. And that is the type of situation we seek to continue to increase happening for more of our folks who are dealing with this. And then one of my areas of research and an emerging topic is the concept of oligometastatic disease. Oligo is the Greek prefix for few. So if somebody only has a couple of sites of metastasis at their diagnosis, do we want to do some local therapy and treat this more aggressively, or does that not make sense? And we really just want to focus on systemic therapy, stuff that goes through the whole bloodstream to try and keep all of the cancer under control without reaching for any local targeted stuff. So let's just talk about the MBC subtypes, because this is what I think is one of the main medical topics I want to make sure you guys are aware of where we are right now. So historically, we've grouped MBC into three big buckets: the hormone receptor or estrogen receptor positive, HER2 negative subgroup, the HER2 positive breast cancer, and then the triple negative breast cancer, where estrogen receptor, progesterone receptor, and HER2 are negative on for all three. But that's kind of yesterday's news. Where we are now looks a little bit more like this. So if somebody's main subgroup is that they're estrogen or hormone receptor positive, HER2 negative, we also need to now factor in all of these other things. Is their HER2 truly zero, or are they low positive? And I'll talk about that more in a moment. Do they have the wild type baseline, or has their estrogen receptor, ESR1, undergone a mutation? Same thing, there's this thing called PI3 kinase, which is just a different gene. And in breast cancers, that can either be wild type or not changed, or mutated. And certain mutations are very important for us to identify. And then, of course, many folks who get diagnosed with breast cancer ended up so because they inherited a BRCA gene mutation from their family. So everyone dealing with MBC should know their BRCA status, regardless of their age or their family history. In the HER2 positive set, that's still a real dominant pathway by how we think about these cancers, because it's such a driver of how those cancers behave. And so we really only then focus on, for the moment, are they ER positive or ER negative, for considering additional options in how we do our treatments. And then for the TNBC space, it looks a little bit different. We care about this marker of immune sensitivity called PD-L1, and there's a couple of others out there. So everyone with TNBC should have had their cancer tested for PD-L1 and know if it was positive or negative and what the role of immunotherapy is for their care. They also now need to know about this HER2 zero or low status, and also their underlying BRCA status. So, and again, I want to just focus a little bit on this HER2 thing because it's changed vastly in the last year. So HER2 is a gene that's in every single one of our cells, and in a percentage of breast cancers, there's too many copies of this gene inside the cell, and it leads to an abundance of this protein being expressed on the cancer cells, and that leads to a cancer that can behave both more aggressively, but also then be very sensitive to HER2 targeted treatments. At the start of my career, this was one of the worst type of breast cancers we dealt with, and now it's one of the most treatable, most curable, even sometimes in the advanced setting. So it really flipped itself on its head. In the olden days, when we would talk about HER2 positivity or negativity, there's two tests that we use. One is a stain of a protein on the surface of the cancer cells. So if you have a lot of the protein, there's a lot of this brown stain. and you would be called 3+ for the amount of stains seen, and that's considered positive. If there was none or very little, that would be considered negative. If there was an intermediate amount, then there could be another test run, which would actually look at the number of copies of chromosomes inside the cell. And if you had too many copies of the HER2 gene, that was called amplified, and that would put you into the HER2 positive space. And if it was not amplified, that would put you into the HER2 negative space. So for 2 decades, we've told everyone they're either HER2 negative or HER2 positive on the basis of this discrimination. But this has now changed. We've modified it to have a middle category. And if you've been told you're HER2 negative, regardless of whether you're hormone receptor positive or TNBC, you need to know if you're a true negative, meaning there's none of this there, or if you're in this HER2 1+, 2+, but not amplified low category, because our treatment pathways have changed. So what does it look like now? Hang on. What it looks like now is this. So if you're really 0, it's HER2 negative. If it's a little bit, these middle zones, you're now called HER2 low. And positive hasn't changed. Positive is still positive, and that's kind of its own thing. And we treat these breast cancers this way. But this opens up an opportunity for either for folks who would have previously just understood themselves to be HER2 negative. So the other thing that's rapidly changing is there's all these new things that we care about today that I would want everyone to have a conversation with their doctor to understand where they are. But this is just the beginning of the alphabet soup that is coming forward for us to know all these different possible things that we could use to explore added targets, or as you heard Abigail mention, repurposing of drugs that we use in one cancer space, but are now going to move forward. Like in the PI3 kinase setting, that's a standard of care drug we use if the tumor's hormone receptor positive, but it's also currently being studied for HER2 positive and TNBC. And there's many, many more targets coming. And then what's also super cool is there are also new types of treatments which are using some of the old targets, but expanding the potential of how we could hit those cancer cells better. So I'm going to give you an example of that in a minute. So a legit question is, all right, well, that's great, but how do I find this out? So things like HER2 low and the PI3 kinase can be identified anytime from prior tissue. So it could be the original tumor that might have been in someone's breast many years ago, or a biopsy of metastatic cancer at some point in the future. You can also identify something like the PI3 kinase by using a circulating tumor DNA sample, which would be commonly called a liquid biopsy. So somebody takes your blood and it gets sent to a commercial lab and it can be found there. Some of these can't be done on bone biopsies, and some folks with metastatic breast cancer have bone only involvement. So that sometimes gives limitations, but that can be thought about for the future. BRCA is something that the person is tested for. It's not coming from the cancer. That's your hereditary gene panel. So that would be done off of like a blood draw or saliva. ESR1 is something that we can't test until somebody has had metastatic breast cancer hormone receptor positive for a while, because this actually evolves under the pressure of the prior treatment. So that's something that we're looking at more typically second line or downstream of that. And PD-L1 can be done anytime, but again, it's one of these ones that has to be done specifically on the tissue. And these are just some of the drugs that are now available to us that make these things our top priorities. T-DXd is trastuzumab deruxtecan, or its common name is Enhertu. And this is the drug that came about for HER2 low just in the last year. In the PI3 kinase space, we have had alpelisib for a while. And of course, we've had PARP inhibitors specific for BRCA cancers, and a whole slew of novel drugs that are estrogen receptor blockers that are different than what we've had for many years. So SERD stands for selective estrogen receptor downregulator. And one of the ones that's been around for 20 years is fulvestrant, also known as Faslodex. But there are now oral versions of these drugs coming along, one of which is called elacestrant. And that is just recently FDA approved. And then, of course, we use PD-L1 to think about use of immunotherapy. So why does this matter and how has it helped? for many years, we had a litany of different chemotherapy drugs that we could use for all forms of breast cancer. And if a tumor was hormone receptor positive, we would use those hormone blocking drugs first and then go on to chemo when the cancer was looking resistant to that. If it was triple negative or in the setting of HER2 before we had drugs like trastuzumab, we would just use these chemo drugs in sequence and get as much benefit out of that as we could. But in general, they didn't offer us a whole lot of long time benefit. So a patient could be on these chemo drugs, but whether it would work for a handful of months or many months was kind of where we were stuck. And so moving forward with some of the big advances, you've heard me mention trastuzumab, also known as Herceptin. And I just want to use this as an example. So it's been originally designed for HER2 positive breast cancer, and it basically mimics a molecule that our immune system would make, a monoclonal antibody, which is something our immune system would make to fight a disease like an infection, but it targets this thing called the HER2, which is on the cancer cells. Now, this came about and it revolutionized how we treat HER2 targeted therapy. In the modern era, we use these things now called antibody drug conjugates. So it's selectively taking advantage of the fact that we know how to find this target on a cancer cell. But the difference here is these modern structures have a payload. So linked to this now is some form of cancer killing molecule. Currently, these are mostly chemo drugs. And there's several of them. So TDM1, which is Kadcyla, sacituzumab govtecan, which is Trodelvy, newer ones coming down the pipeline that aren't FDA approved. This one might be soon, datopotamab, and then there's many, many others. So this is a super sophisticated way of taking a chemotherapy molecule, but getting it directly to the cancer cell. And it binds to the cells that express the marker, but it also has this bystander effect in that it's kind of leaky, like the chemo goes to the surrounding cells and can kill them too. So you don't have to have like the strongest level of expression of the marker, like the example of HER2 that I've been giving you. But you can just get it to enough of the cells that it will also leak around and kill off the ones next to it. So this is going to be something that really revolutionizes ongoing opportunities for creating even more folks who are living well for longer with their cancers. And here's why. So these are the results of one of the clinical trials that got this drug, TDXD, or Enhertu, approved for HER2 low breast cancer. So this is what's called a waterfall plot. So this is a great thing for you guys to understand as you're going to meetings and you're looking at scientific data and you're trying to ascertain, does this look something promising to me? So what this is each one of these bars is a person who came onto the clinical trial. And they either received the study drug or TPC is treatment of provider and patient's choice. And these were standard chemo options. In this case, down is better. And all the way down represents someone who got a complete response, meaning there was no evidence of disease or no evidence of active disease. So you can see immediately that there are way many more people who were treated with this experimental drug who achieved that than what we would expect with just standard chemotherapy. And even if they didn't get 100% of a response, they got a whole lot more of them got a significant response, and only a few did not derive benefit at all. That is in comparison to standard chemo. So this is a big frame shift, and it got docs like myself very excited, because while the most important thing is overall survival, as you heard Abigail mention, it does matter that we can kill the cancer, kill it well, and really push the disease back. Because if you can reset the burden of disease somebody is living with, then you get better results for progression-free survival and overall survival. And this also tells us that if somebody is getting sick from their cancer, you're going to have a much better chance of fixing that quickly than if you're giving standard treatment. So this is what's called a progression-free survival curve, and this is what doctors look at. And don't get freaked out by numbers on this curve. This has nothing to do with an individual patient. But what we want to look at is the difference between a green line and a blue line. So you want the blue line to be as flat as possible, because that's how many people are alive and well. And each time this line goes down, it represents progression. And you might think, well, gosh, these curves look horrible. But what I would ask you to just focus on is 12 months reflects what percentage of women would still be benefiting from their treatment a year after they've gone on it. So in this particular clinical trial with folks who came onto it, if they got regular chemo, only about 20% would still be on that same regimen a year later, whereas we're up to practically 50% by the use of this novel drug. So to be able to get longevity and longer benefit out of a particular drug really matters. And this was in all patients, looks about the same. This was just the hormone receptor positive subset. So there were more hormone receptor positive patients in this trial than TNBC, but both were included and all of them had about the same benefit. So this is something that a doctor looks at and says, this is great. And, you might look at it and say, okay, well, yeah, I'd rather get, I'd rather have a 50% chance of getting a year's benefit than a 20% chance, then tell me about the side effects, right? But this is how we make progress in the field and move these things forward. All right, so you might say, well, doc, that was a little overwhelming. How do I know what I should be on and what should be my next choices? I am an academic doctor, and I would just say that there is good clinical data to say that women who avail themselves of clinical trials tend to live longer and have a better history with their cancer. And I think that both represents who women are who avail themselves of these treatments, but also the fact that you're getting access to some of the hottest clinical things out there. It does matter what type of clinical trials we're talking about. So phase 3 are typically randomized studies that's trying to get a drug new and approved, so that it will be compared to what the old therapy was. And there might be a placebo, but everybody's on an active agent. Phase 2 tends to be hot combinations of things that we think may add to each other, but it's not being compared to anything yet. So usually there's no placebo, no randomization. Sometimes there is, but in general, it's a little bit more like what happens right before a drug gets to be in a phase 3 study. Phase 1 often has a bad connotation, but there are a lot of phase 1B studies, which are drugs that are already FDA approved, but we want to see how they work together. So the example I gave you a minute ago of, we're starting to look at PI3 kinase in other different subtypes of breast cancer. Well, that drug's already FDA approved. And so, what we want to look at is, can we incorporate something we already know how to use with drugs we already know how to use and make a combo that will work even better and prevent the cancer from becoming resistant or developing progression for longer for more of our patients. Then there's the true phase 1 studies, which are first in man. This drug's not been given to people before. And whether we know that this drug is super specific for a subtype of breast cancer and then quite promising or not is something that has to be discussed at that time. So this tends to be for folks who have been living with MBC for longer. They've gone through some of the other options, but they're still very fit and healthy. And how much sense it makes to consider one of these at some point in a treatment path is a very individualized decision and worthy of always discussion. As doctors, we have very specific algorithms we follow based on what the clinical trials taught us. Drugs get studied in a specific line of therapy, second line, third line, later line, or first line. And that's how these algorithms become available. And this is just one example that a lot of US oncologists use, the NCCN guidelines. My institution is one of the NCCN institutions by which we write these guidelines. So I don't just follow the guidelines, I write them. And so, as you heard Abigail mention, a second opinion is always an option, and how valuable kind of depends. Certainly if somebody is newly diagnosed with MBC and it's, estrogen receptor positive, HER2 negative, the studies that got the drugs currently in the first line setting are pretty bulletproof at this point. And so, all oncologists should be able to offer the right answer to that. If it's second line, third line, if you're interested in a clinical trial, if your cancer situation is a little bit more tricky, TNBC can be a little bit more tricky. HER2, we have a lot of great regimens that we use. And so maybe the standard of care choices will be the right choices for first line, second line, maybe even third line before it would get to the point where seeing a second opinion matters. But it's important to know your environment. So most of breast cancer in the United States is treated by my colleagues who are general oncologists. They walk out of the room seeing breast cancer. They walk into the next room, it's lung cancer. They walk into the next room, it's pancreas cancer. You get the idea. I don't do that. All I do is breast cancer, and I'm an academic, so I do both the research side of it and write guidelines and come talk to folks like you. So having that level of input of someone who only has to think about one thing, right? I've been thinking about one thing for 25 years, so hopefully I get it right, is a little bit of a different interaction and dialogue and knowledge base than you might get if your wonderful oncologist who's doing a fantastic job taking care of you is more like one of my general oncology colleagues. And I work with a lot of those docs and see patients in conjunction with them, even though I'm not the person who actually treats that person. So I want to pause there and flip back over and hear what you guys want to talk about.
Great. Thank you, Dr. Borges, for that amazing presentation. And we're always pleased to have you back with us. And Abigail, you as well. Lots of wisdom from the patient and oncologist perspective. So I'm going to start with some define your terms. As you mentioned, Dr. Borges, some people hearing you go through the subtypes and asked, what is this wild type? What does that mean? And
so another word you could choose to use for that, although it's not the scientific term, would be not mutated or just normal. So all of us have these genes in all of our cells, and they exist as a normal state. When one of our cells, breast cells in this case, becomes cancer or becomes metastatic breast cancer, it acquires different mutations that makes it less normal. And so wild type would mean the mutation is not there and the drug's not going to benefit you. Mutated, which kind of sounds negative, is actually potentially a positive because it opens a treatment option. So again, these terms can get confusing because sometimes positives are negatives and negatives are positives. And mutations, which can sound weird, are often just a method by which we can identify, is this a cancer that has an extra tool in the toolbox that we can think about because this drug's been developed versus not. So try not to put any emotional attachment to any of your mutations.
Okay. Some people have also asked, when you have a progression, does your subtype change? And how, and if so, how frequently do subtypes change?
So there are times in which we think about that more and times where we don't think that's likely. So if somebody has been previously treated for breast cancer and is now facing metastatic recurrence as a first event, it's considered incredibly important to try and biopsy that and identify, does it look the same as it used to? Because it's upwards between 10-15% of the time that some of the markers might change. And so it can be almost anything. So oftentimes estrogen receptor will go down or potentially go away. HER2, if it was there in the beginning, usually stays, but that's not 100% guarantee. If a cancer was triple negative in the beginning, it's most often triple negative when it comes back. But since there are a lot of tools that could be considered as treatment options, should there be some turning on of the estrogen receptor or the HER2, we just got to know. And so it would be considered absolutely standard and obligatory to try and biopsy something and get that information at first metastatic recurrence if you can, right? Not all metastases can be easily biopsied or safely biopsied. Mm-hmm. We now have these technologies with these liquid biopsies that can sometimes give us this information, although it depends on the marker, as you saw on my table. And then in my personal practice, as I'm working with my folks as time goes by, if there's ever an unexpected progression or a big change. So for example, if I have a patient who's had only bone metastasis and I've been treating her for that for, I don't know, 6 years, and all of a sudden on a CAT scan or a PET scan or whatever marker we were following, there's a big change and we see, oh, well, now there's a liver lesion. I'm going to go biopsy that liver lesion because something about her cancer or his cancer has changed over time. And so I should figure that out because it's now showing up in a new spot. What's been super complicated with the pandemic is I see patients all the time who have changes in their lungs and they're not cancer. If they had COVID, we can see all sorts of interesting things. And so what we often do is just maybe wait and watch and not get too excited about that and start poking holes because it can oftentimes not be cancer. And I have patients where things have changed on their scans and and it was a new site where their cancer had never been before. And we did a biopsy and it's not their cancer, right? Women can get other illnesses. So I've had plenty of patients who they started getting some lymph nodes in their chest and we biopsied it and it was sarcoid, an immune disease that women can get. And so I don't want to change their cancer treatment because of something that's not even cancer. So I don't biopsy every single time and I don't go looking every single time because they don't tend to flip-flop that much. But you do want to periodically check, maybe every couple of years, and also at any time that there's something really different about what the cancer is doing. That's a good time to question, how much have you changed that you're now doing this?
Yeah. Well, thank you. And I'm glad Abigail's back. I'll get a question to you in a second, but just a number of people have asked, like, when you do have a progression, what tests should you have at that time?
Again, a little bit dependent, but I'll give you an example of where I would not test, right? So I'm treating someone and their prior sites of cancer that were identified when they first developed metastatic breast cancer had all responded lovely to their treatment. And it's now some years into the future. And one of those known spots is growing or lighting up again. You could decide. It depends on how many years it's been. It depends on how much information you already have from prior biopsies, right? Like some of those markers we already know from the original tumor. But if somebody is ER positive and now progressing, and I'm wondering, could their cancer be a little bit more resistant? Has it developed that ESR1 mutation? I could send off one of those liquid biopsies. That doesn't take a lot of time and it doesn't require any invasive procedures. If somebody has triple negative breast cancer, depending on how that cancer's been behaving, been responding to things, I might be a little bit more aggressive about wanting to get that information with greater frequency just to see, because those cancers can sometimes change more. Although, it just depends. If I'm already 100% certain what I think I want my patient to take next, then I don't know that we need to go put them through the time and effort and co-pays and trauma. Right? Everything we do causes some trauma of getting a biopsy or even waiting for the results of a liquid biopsy. So there's no one right path. I would say every single time is too much. Never is absolutely the wrong answer. And the Goldilocks just right is a little bit in between. Now, I've mentioned ER positive, I mentioned triple negative, I haven't mentioned HER2. Well, in reality, those assays, those tests don't tend to be super helpful for HER2 because all of the treatments we use very much target the fact that HER2 is such a dominant gene that makes these cancers behave uniquely. Now, I will do a test like that if somebody is not benefiting from their HER2 targeted therapy the way I think they're supposed to, right? Like if things aren't working the way that they should, then that makes me think, well, what's this cancer doing? And then I will go do that. But probably the patients of mine who get those types of tests the least will be my HER2 folks. And my TNBCs will be a little bit more often. And then my ER positives, maybe not that often, but it's changing based on the advent of some of these newer drugs coming for us.
Yeah. So I think maybe the takeaway is talk to your doctor at progression and ask some of these questions. That is really helpful. Abigail, we have a lot of questions about sort of your advice about progressions, seek a second opinion. When is the time to do that and how to do that?
Such a great question, because in the chaos of progression or the chaos of learning something new, that can be a huge, heavy lift. And so, in my opinion, establishing relationships with other doctors during times of stability, during times when it's not so crazy in terms of appointments and making all those decisions, is really key. I'm in Florida. I have a doctor that I see regularly at Memorial Sloan Kettering in New York City, and I found one of the doctors who is licensed in Florida, so I can do telemedicine and I don't have to fly up to New York. So that's one example of how you can make it a little bit easier. To me, always looking for an NCI designated cancer center is important for second opinions. And in my experience in dealing with a whole lot of insurance companies, those cancer centers really know how to help you get the second opinion covered. I have found when I go to a community oncologist, my insurance company is far more likely to fuss about something and raise questions and require peer-to-peer discussions. When I go to Mayo, they don't do that. And so I think some of it really depends on the organization that you're going to. But I also would say is there are two generally types of second opinions. One is actually seeing the doctor and having that one-on-one conversation. The second is a records review. And so a lot of the larger cancer centers, MD Anderson, the Mayo Clinic, MSK up in Memorial Sloan Kettering up in New York, they will have doctors who will review the records and provide a written recommendation or a written analysis, which can oftentimes be a little more accessible, especially if you can't get a telemedicine appointment or it's hard to travel. And again, those organizations are really good at working with various health insurance companies to get those things approved. Great.
Thank you. Well, Dr. Borges, I understand you have some more slides to review.
Could I say something really quick? I just wanted to throw this in. So I have the germline mutation ATM, meaning I inherited that from my family. When I was originally diagnosed, they only did BRCA1 and 2, the BRCA mutations. We're not positive for those things. And it was only later, once we realized I was metastatic, that they did the full genetic panel. And while ATM is a moderate risk gene, somewhat different than BRCA, which can be more of a high risk gene, understanding that there are many other mutations other than BRCA that may be influencing or may be affecting your experience, I believe is super important. And an organization that I would highly recommend you look up if this is something that you're concerned about is FORCE, Facing Our Risk of Cancer Empowered. So they have genetic counselors on staff. We have some wonderful support groups that we're starting, especially for those of us in this moderate risk gene category. So if you are in that small minority, we're still a small minority of people who have an hereditary cancer that has something to do with your cancer diagnosis, getting information about that is really key. And I think can be really empowering to be able to take some control back in this out of control experience. So just wanted to say that as well.
Great, thank you. Thank you. Dr. Borges, I'll turn it back to you.
Thank you so much. And while I'm waiting for my slides to come up, I will just say that was a super point, Abigail. There are 9 genes which are associated with increased risk for breast cancer now, some of which are actionable in terms of we have drugs that could target them, but also just for the importance of understanding what your family faces in terms of risks of cancers and other cancers that an individual person living with metastatic breast cancer might face. I've had the weird scenario of a patient where her MBC was under great control, and what ended up coming up was a totally different cancer that we didn't know she was at risk for because it was one of the genes that we didn't know about back then, and she had never been tested for it. So very important information as well. So in my many years of looking after women who are dealing with MBC, and I should say women and men because I have done both, is the concept that this is the marathon you didn't sign up for. And in Colorado, I use the analogy of the Leadville 100, which is this quite notorious nasty run that people will subject themselves to. And once someone is living with MBC, there's a lot of challenges to this, right? There's the psychology of illness, that this is an ongoing part of your life, and that you have to kind of navigate that. And it changes how people interact with you. It changes how your family, your friends, your loved ones interact with you. It changes how your employer interacts with you, and even how you interact with yourself. And so identifying that and figuring out what that means for you as an individual, and reaching out and getting supports that help you manage that is important. I am never more surprised by what Americans will say to someone when they tell them that they are living with a diagnosis like MBC. It's a particularly unique challenge of our culture. And so, how you set your boundaries and how you choose to define when this is something you're willing to talk about and how you're willing to talk about it with others is incredibly important. And I think you guys can lean on yourselves more than someone like myself would ever be able to help you with that. But as physicians, we see and hear some of the craziest things that our patients go through. And I think also it's hard because breast cancer is at least once a year for a month on everyone's mind, and there's a lot of pink. And we often define breast cancer in terms that are things like warriors or survivors, very, very warlike terms, which not everybody resonates with. And so how you navigate this culture of breast cancer, particularly here in the United States, and incorporate that into your life is hard. And how do you face the issues of, okay, I've noticed my tumor marker is going up, I've got scans coming up, I'm worried about all this, the mindset of how you deal with that, while you're also still just basically a human being trying to get through the day, right? We all have nights where we just want to get the dishes done and go to bed, but you've also got this added layer that is constantly with you. And it can obviously cause strain on relationships, and those relationships can be strained in different ways. You have the people who lean in too much and want to tell you what you're supposed to be doing and everything they've read about. And then you have the folks who pull away and who don't engage in the same way, or the folks who engage, but they only ever want to talk about your cancer situation when really you might want to have a different topic. And then I use this example with my patients on the emotional side of things is, there are a lot of things we can do to support the mental health of our patients so that this crazy roller coaster that you didn't sign up to get on could be more the kiddie coaster as opposed to this constant extreme scream ride. Because as you all know from firsthand experience, there's anxiety, there's waiting for the next results. I know my patients, when they come to see me, I'm an anxiety-provoking event. Even though I try to use humor, I try to be a normal person when I'm talking with my folks, but at the same time, I'm not easy to come see, right? What do I represent? And even more for the folks who are coming to see me for these remote second opinions that we all do at the academic centers. They don't even know me, and yet I'm going to outline to them everything and that I think they might need to do about their cancer. Extremely emotionally provoking moments. And so our culture doesn't do a good service to women because we are supposed to somehow work and raise our families as if we don't do the other. And then folks living with MBC are supposed to, focus on their MBC like nothing else matters, but also raise their families, work, do whatever it is they do in their lives as if the MBC isn't a part of it. And then you add to it on top of the fact that America does a terrible job of embracing the fact that the brain is just an organ. Our mental health is just a part of our lives that needs to be managed no matter what we're going through. And yet there's a lot of cultural stigma against the idea of taking medications or therapy or counseling or the opportunities we have to support our emotions and support our brains. And so I spend a lot of legwork with my patients trying to get them over that. How do we deal with the fact that you're both a long-term well person, but technically you have a terminal disease? And the reality is some of my patients are very likely to outlive me the way things are going. So I'm not considered to have a terminal disease, but they are, and they have to live with that. This is a piece of artwork called the Sword of Damocles. And this king had to live with the sword over his head, never knowing when it might fall and kill him. And that's the example I give to a lot of my patients is, how do you cope with this fact that you've got something that could at any moment kind of try and do something bad to you, versus you're also supposed to just live your daily life, particularly when you are well and doing fine and things look good. So this is just a long list of what I see my patients embracing and what can be of benefit to them. And then there's some more challenging topics, like, is the treatment even worth continuing on with? And this is where important conversations about goals of care versus quality of life come in. And so, yes, we can certainly offer progression-free survival, prolongation of overall survival, but at what cost? You heard Abigail gave a great overview of 5 important things in the beginning. And what I can tell you is that in most cancer situations, we definitely want our patients to be willing to think about going through multiple lines of treatment, because treating the cancer improves the quality of life, whether it is prolonging life, because it will prevent symptoms, prevent loss of function, and just be an improvement to the overall situation. But there does come a time, depending on the disease and how the treatments are going, where maybe that stops making sense. And so that should be a part of the conversations that folks are having with their doctors, particularly if they are on 6th, 7th, 8th, 9th, 10th line therapy. There isn't really a limit of therapies, but there is sometimes a limit of what makes sense based on how sick the person is, how well they could withstand further treatment, and most important, what their personal goals of care are and how they would like to handle that. It leads to what I call some of the scarier topics and the darker side. What do I expect from my patients? It varies a lot by the subtype, as you've heard me allude to. And any cancer, whether it's a subtype that we think is going to be more treatable or less treatable, can behave differently on both ends of the spectrum. I have patients with TNBC who are exceptional survivors, and that is not what I counseled them when I first met them. But as time goes by, we have to re-update and re-converse about this stuff. And then when, as a physician, do I bring up what I know my patients find scary? Palliative care is a fantastic opportunity to have additional people looking after you and taking care of you who are the experts in symptom management. If I have a situation where I'm struggling to make one of my patients feel better, I will engage them sooner rather than later, even though I know this patient is going to be on treatment with me for years into the future. But it's just great to have more minds, more help, more hands, and more experts. Hospice is something that we do think about when it's not really going to serve someone to continue on with active anti-cancer treatment. That's usually someone who's been dealing with things for, a lot longer, and the organs aren't working quite right, or it's just not feasible to keep giving ongoing treatment because it's going to do more harm than good. We know from a lot of clinical trials that there comes to be a point where we're just not going to benefit them, and we should stop pounding them with drugs that are going to cause nasty side effects and hasten their demise. Sometimes my patients will want to talk about what they can actually expect of their end of life, meaning what are their family going to see? What are they going to experience? And that's something that I personally feel very comfortable talking about with my patients, but not all oncologists do, but all palliative care doctors do, because that is a part of what they do for a living. And so if your personal doctor, who's the one who prescribes the treatment, isn't particularly good at that, all the more reason to meet a palliative care team sooner so that you can have that stage set. And I use my can of worms analogies, when to talk about this, preferably before you're ever there. So, these topics are kind of like having a can of worms, right? And you just, sometimes you have to take the lid off and let the worms crawl out and crawl all around and look at these dark topics and try and understand, well, what do I want? What does this look like for me? Knowing that none of us can foresee the true future. But then you got to get all the worms back in, put the lid back on the can, and go back to your life living with metastatic breast cancer. But it's never a bad idea to touch the dark side and then come away from it so that you have an understanding of what matters for you, because you're the one who's going to have to tell your loved ones and the people who are going to have to help you make the decisions when you're not going to be the one who can make them for yourself. And so it's most important for you to know what you want before you try and tell them, or they have to figure it out for you. So let's go back. I know we're a little bit over time, but we can run over a few extra minutes and address some questions and talk about that stuff.
Okay, well, I think there were questions about financial toxicity and drugs. There were questions about managing pain and grief that comes along with this diagnosis. And Dr. Borges, if you could just touch on one of those things. We have workshops about many of them, but if you could just touch on those for a minute, and then we'll close out.
Well, financial toxicity is huge and real, and the longer you live with the disease, the more it builds up. So it is a reason to have realistic conversations with your care team about, if there's a new drug that's just come along, but in comparison to the old drug, maybe it's not such a game changer. Maybe that's not the one you reach for, right? Abigail made the great point of the oldies but goodies, right? The reason they've been being used for decades is because they actually work. And some of the snazzy stuff that has come along with a lot of hype to it was kind of really ho-hum and me too. So you want to make sure that when you're thinking about a new drug, did it have one of those gorgeous waterfall plots or big separation of the curves where we as people who recommend these things to you think that's the bee's knees. That's the thing to really think about. And maybe it comes with some financial toxicity or some side effects, but the bang for the buck of what you're going to get out of that can be expected to be a lot bigger than, the Me Too drug that was the second one FDA approved and costs $10,000 more, but really isn't going to get you anywhere. And so those are the times where maybe your local doc who's taking care of you is the right person to ask about these things, but maybe that is when you want to go get like a remote second opinion or come see a consultant at an academic NCCN institution like mine or many of the ones that Abigail was mentioning. Does that sound fair, Abigail? I see you're nodding. Yeah.
Yeah, 100%. And also asking around to other patients. Doctors are wonderful and doctors have great experience and can provide opinions, but don't forget that peer support too.